Hello, everyone. Good morning. It is a pleasure to be here with you today, and welcome to the May 2026 UCLA Tarjan Center Distinguished Lecture Series. I'm Dr. Jasper Estebillo, Director of Training for the Tarjan Center, and I'm very happy to be hosting this month's lecture series. As we welcome you to today's lecture, we'd like to thank and acknowledge our co-sponsors, the UC program, the UCLA Center for Autism Research and Treatment, and the UCLA Intellectual and Developmental Disabilities Research Center. A couple of reminders before we get started. Firstly, please remember to enter your questions for our speaker into the chat, or I'm sorry, into the Q&A. And throughout the talk, we'll gather all of your frequently asked questions, and then we will facilitate discussion at the end of the presentation. Please also remember to complete our evaluation survey to provide feedback and suggestions for future lectures. The link to the evaluation survey will be sent in the chat today, as well as in a follow-up email later this week. Now I would like to introduce this month's speaker. We will give her a second to join us. All right, it's just taking a moment for video to load, but hi, Dr. Yu. Dr. Yu is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of California, Davis, and a faculty member at the Mind Institute. She also serves as the co-director of the Maternal Child Health Careers / Research Initiatives for Student Enhancement undergraduate summer program, which is the MCHC / Rise Up program, and as faculty member for the Leadership Education and Neurodevelopmental and Related Disabilities at the UC Davis Mind Institute. Dr. Yu received her PhD in clinical psychology from Indiana University, Purdue University, Indianapolis, and she completed her clinical psychology internship at the Charleston Consortium, Medical University of South Carolina, and her postdoctoral training at the UC Davis Mind Institute. Dr. Yu's research focuses on psychosocial outcomes for caregivers of autistic individuals and community implementation of evidence-based practices for young children with autism. Today, she will present Supporting Caregiver Engagement in Early Autism Interventions, a Mobile Health Approach. Please join me in giving a very warm virtual welcome to my friend and colleague, Dr. Yu. Thank you, Dr. Yu.
Thank you, Jasper. Thank you for the wonderful introduction and this mouthful. I'm going to share my slide. Thank you so much for the invitation to speak at the UCLA Distinguished Lecture Series. Also, thank you to those of you who registered and came to this talk. It is really my honor to be here. Today, I'm going to talk about supporting caregiver engagement in autism early intervention and explore a potential mobile health approach. Here's a quick overview of what we'll be covering today. First, we'll start by discussing the importance of caregiver involvement in early interventions for young children with autism. We'll look at why caregivers play such a critical role. Next, we'll explore some of the common barriers to caregiver engagement. This includes challenges families may encounter that make it difficult to fully participate in intervention programs. Then we'll shift into strategies for supporting caregiver engagement. And finally, we'll introduce FancyEye, which is a mobile health approach designed to support caregiver engagement in autism early intervention in community settings. So let's get started. Children under age 3 with autism or at high likelihood of autism are eligible for early intervention services through the Individuals with Disabilities Education Act, IDEA, Part C. Early intervention for autism typically focuses on building foundational developmental skills in young children. So key areas include social engagement, communication, that includes both receptive and expressive language, so understanding and using language, imitation, and play skills. Caregiver-mediated early intervention is considered the best practice by research and clinical guidelines. So through this modality, professionals train and coach caregivers to work directly with their children. And parents, in this case, learn to implement early intervention strategies through coaching from the early intervention provider called caregiver coaching. Caregivers can implement this intervention strategies in naturalistic settings and during daily activities, such as playtime, meals, or dressing. This provides a more comprehensive and continuous application of the intervention strategies. This method really aligns with the principles of family-centered care, in which families are actively involved as partners in planning, delivering, and evaluating care for their loved ones. In fact, involving caregivers in early interventions is the key mission of Part C of the IDEA. Coaching parents to implement strategies is also a potentially more time and cost-effective service delivery model. Studies have shown that caregiver-mediated early intervention improves child's language and social communication skills. Caregivers showed reduced stress and increased sense of competence. So in caregiver-mediated early intervention, caregivers take a primary and critical role. Therefore, so effectively engage caregivers is important, including consistently attending sessions, actively participating, asking questions during sessions, and also practicing outside of sessions. Before we talk about barriers, let's talk about what or how caregiver engagement is defined. Caregiver engagement is comprised of two components, attitudinal and behavioral engagement. Attitudinal engagement refers to the expectations and perceptions of the intervention, and the behavioral engagement includes attendance, participation in session, activities and discussions, adherence to intervention strategies practiced at home. Why do we need to talk about engagement? Attrition and dropping out of intervention programs early in general has been a significant issue in various caregiver involved interventions that include child caregiver mental health interventions, parenting behavioral management programs, and early interventions for language and communication concerns. The dropout rate ranges from 40% to 60%. Some groups are disproportionately affected and face more barriers to consistent participation. So this rate is even higher in families with limited access to different resources, financial, social, community resources. Different studies have looked at the barriers to consistent caregiver engagement, and there are several review studies discussing different conceptual and empirical factors. Potential barriers include structural barriers, other stressors in life, relationship with providers, and caregivers' perception of treatment. So the first one is the structural barriers. They include things like transportation, childcare, work demands, and other competing demands in life. So thinking about taking time off from work and driving to sessions and finding childcare for other siblings can be challenging, especially for families who have limited resources. Even most highly motivated caregivers may struggle to participate consistently when these challenges are present. So, in families, and the second factor is other stressors in life that families may deal with that can be financial stress, mental health struggles, potential conflicts with other family members, and other caregiving responsibilities, which all can make engagement more difficult. And therapeutic relationships with the provider and caregiver's perception of treatment also impact engagement. So a poor relationship with therapist, which includes perceived lack of support or understanding from the therapist, or not feeling like not being listened to, contribute to premature determination of treatment. And when the intervention is perceived as irrelevant, meaning not matching the priority of the family or too demanding, we see engagement drops. Various strategies have been used to support caregiver engagement in child intervention services in general. For example, Felicia and colleagues conducted a review study looking at the engagement strategies that are most often used to engage parents of children with social, emotional, and behavioral disorders, specifically in families with limited resources. So the most commonly used strategies were accessibility promotion, assessment, goal setting, and problem solving. So accessibility promotion, which is any strategies used to make services convenient and accessible, such as providing childcare, being flexible with location and the time of the appointments, providing low cost or free services, transportation, offering food during sessions, sending out appointment reminders, when caregivers miss the sessions, catching them up on missed materials. Assessment, meaning evaluating kind of treatment barriers early on in the intervention or before the intervention. And shared goal setting means providers and caregivers get together and set explicitly treatment goals and work together towards achieving that goal. Problem solving is training and practicing the techniques and strategies to help solve specific problems now. So addressing families' priority while also with the intention to build skills to handle similar problems in the future. This review also found that interventions that happen at home, not surprisingly, at home or preschools had less parental attrition than clinic-based interventions. Another strategy that showed some level of effectiveness is to pair a caregiver with another caregiver or a group of caregivers. This allows for reciprocal learning, skills practice, and development of a support network. Through this partnership, caregivers share similar experiences, resources, and lessons learned with each other. So more recently, Stamer and colleagues gathered family and provider perspectives perceived barriers and facilitators in the process of getting an autism diagnosis and accessing autism related services. The team interviewed families from three cultural groups, including Black, Hispanic, Latino, Korean families in different states. In this qualitative study, caregivers viewed the support from other families of children with autism or other disabilities as important and critical. Caregivers noted that the networking with other families, going to the support groups, having informal meetings, and calling other caregivers and sharing the knowledge and experience were really helpful during the early stages of the child diagnostic process. And they shared that the relationship with other peers as particularly helpful in keeping them engaged in accessing care. And this relationship really provided them some therapeutic relief through this networking opportunities and conversations about shared experiences. So this is a quote one caregiver shared during one of the focus groups. So after he got the diagnosis, I just shut down. I did not say anything. I did not tell anybody. I could not do it. So one of the moms calls me. She called me at work and I just started bawling. And I told her that this is what happened. So we covered barriers and strategies explored to support caregiver engagement, many of which were reported by caregivers themselves through interviews. And next, I'm going to talk about a specific example that was designed with all these strategies in mind. And this is a caregiver-focused program implemented in community settings. So for some context, the Autism Intervention Research Network on Behavioral Health, AIRB, is a national network of researchers and community partners who are dedicated to improving behavioral interventions and outcomes for autistic individuals. It focuses on developing, testing, and implementing evidence-based practices that addresses the needs of those underserved communities or communities with limited resources or access to care. The lead principal investigator of AIRB is UCLA's very own Dr. Connie Cassery. I had the opportunity to work on one of the ARB's programs, Mind the Gap, with Dr. Alban Stamer at the Mind Institute. Mind the Gap is funded by the ARB network. It aims to empower families of children who recently received a diagnosis of autism or other neurodevelopmental conditions through kind of bridging the gap between the new diagnosis and access to critical services. This project challenge kind of addresses the challenges that families often face, such as understanding the diagnosis, navigating the complex healthcare and educational system, understanding what resources are available to them. Mind the Gap is developed through a community partnered participatory research approach. The program materials and structure were co-designed by caregivers, autistic individuals, service providers, and community organizations. The program pairs caregivers with trained peer navigators who, based on language and location. And those peer navigators are parents or primary caregivers of children with autism or other developmental disabilities. They have prior lived experience navigating the autism service system. They help provide education, guideline, and support that are guided or by a caregiver's goals through coaching sessions and resource materials. So caregivers and peer navigators are asked to meet 12 sessions over 18 weeks. And the meeting formality or meeting modality is decided by the dais. That can be in person, can be through Zoom or over the phone. And during the intake session, the first session, the peer navigator meets with the caregiver and conduct an intake interview through which they kind of gather information about the child's strength, the current support the family is receiving and their needs, and explore caregivers' priorities and goals. So the results showed that after the Mind Gap program, caregivers demonstrated increased knowledge of autism, increased professional networks, improved sense of empowerment when interacting with other service providers. Caregivers identified that their relationship with peer navigator as the most beneficial feature of the program. I was interested in looking at caregiver attendance patterns in their mind gap session and conducted a latent class analysis, which is a way of grouping people or explore some underlying categories that are hidden or not directly observed based on patterns in responses and behaviors. So in this case, we used attendance as a proxy of caregiver engagement, and we examined session attendance after the initial intake session, so starting from session 2. So on average, caregivers attended 7.77 to 8 sessions, and through the latent class analysis, we retained a three class model: high attendance, low attendance, and intermittent attendance. 49% were in the high attendance class, 19% in the low attendance, and 32% in the intermittent attendance class. So members of the low attendance class had a lower likelihood, about 29%, of joining the first session after intake. And the attendance was consistently low throughout the sessions. And in the high attendance class, the probability of attending sessions stayed relatively high over 18 weeks. Members of the intermittent attendance class were more likely to attend the first session after intake, about 56%, compared to the low attendance class. Their probability of attending sessions dropped around week 6, after week 6, with some periodic increases every 2 or more weeks. We explored different child and caregiver characteristics that are associated with this attendance pattern and didn't really find relationships with most factors except the employment status. So participants who were employed were more likely to be in the low attendance, whereas those who were stay-at-home caregivers were more likely to be in the high attendance and the intermittent attendance class. So this is consistent with the literature that the competing demands impact caregiver engagement. Attending sessions may require taking time off from work, adjusting work schedules. When caregivers' work schedule is not flexible, missing work may have financial and job-related consequences, which are not always affordable by all families. All these findings suggest that we probably need to address some critical materials early on for some caregivers before they have to drop out of the study early. Provide provide additional support at the initial sessions, part of intake or goal setting to retain employee families, potentially emphasizing flexible scheduling or emphasizing buy-in. Maybe we need to condense the materials and offer shorter programs to some caregivers. And also, given the drop in attendance after week 6, maybe we need to think about whether to reassess the family's needs, reassess and develop new goals around week 4 or 5. So this attendance pattern suggests that even with the support and strategies in place to enhance or support caregiver engagement in this caregiver-focused program, the attrition rate is still relatively high. But what more can we do? What do caregivers rely on? What has been done in other health fields to support patient engagement? And so far, the literature has focused mainly on challenges and struggles. And I want to explore additional strategies in supporting caregiver engagement using a more strength-based approach. So various studies have shown that caregivers rely on families for additional support, whether that's emotional support, instrumental support, or financial support. For example, when Stamer and colleagues interviewed families about their perspectives on perceived barriers and facilitators in autism diagnosis and service access, caregivers shared that their family members were helpful in many areas of their lives. So common support included babysitting, housing assistance, and moral support and advice in transportation. Social support has been shown to be related to lower levels of caregiver stress, higher levels of caregiver and family well-being, and positive parenting attitude. So thinking about including all this information, relying on existing social support network may be a potential strength for families that can be harnessed in facility engagement in early intervention. So we learned from the literature and the focus groups that caregivers identified receiving support from peers who have similar experiences as critical. So during Mind the Gap, they were paired by others and by the research team with a peer who had similar experience. What if instead of creating a new connection, we focus on the existing support system that's already in the family's life, such as family members, friends, neighbors, their community or cultural networks? So integrating family and friend network or support in intervention programs has been widely used in health research, such as managing chronic disease, substance use, or weight loss programs. Based on a support, this one specific example is based on a social support framework. Berner and colleagues examined a mobile health intervention called Family Friend Network Support, which is designed to improve social support and self-care behaviors in low-income Latino patients with diabetes. So participants nominated a family member or a friend to participate in the program with them. And we're going to call them supporters. And the supporters receive three types of text messages from the research team, kind of prompting them to provide different supports. As instrumental support, providing tangible goods or actions, or informational support that provides kind of knowledge in healthy living habits, or emotional support. So the supporters and caregivers receive similar messages at the same time, and their messages really mirror each other's. So here are some examples included in the author's publications. So educational or motivational message could be 30 minutes of exercise a day, even walking, will give you more energy, not less. Make it part of your routine. One example message to the supporter could be remind Maria to serve food on a smaller dish. This will make it seem like more food is being served. And Maria is getting a message with similar content. So the results show that participants demonstrated increased self-monitoring behaviors and reported improved motivation and the relationship with the participating supporter. So, what's the benefit of using a mobile health approach? So, typical social support interventions or programs may require in-person training of the family and friends supporter. And you need to coordinate the schedule and physical locations between the caregiver and their supporters. And there might be additional cost from providing the physical space and personnel. And because of these factors, the options of supporters that can be nominated by the patient or the participant can be limited. So it has to be someone who have time to be trained and or to be proximate to the caregiver. A mobile health approach can overcome the transportation and time commitment obstacles. So caregivers can essentially select anyone from their social network, regardless of physical location. So this is what we kind of talk about so far. We talk about caregiver engagement is really important in autism early intervention. Caregivers encounter barriers to consistently attend and participate in sessions, and these barriers impact some families more than others. The literature has explored different strategies to improve and support caregiver engagement in caregiver involved in intervention programs. We discussed specific examples of utilizing those strategies. Mind the gap, and families reported using existing social support that they have. I want to explore a strengths-based approach, building on what families already use and have. This has been examined in other health fields and has shown positive outcomes in behavior change. The next step is to adapt it to autism early intervention, which leads to the next topic that I'm going to cover today, the Family Friend Network Support Early Intervention, NCI. There are three main goals of the project. One is to collaboratively adapt the mobile health program to support caregiver engagement in autism early intervention, and to examine the effectiveness of FNCI program for improving caregiver engagement, and explore how FNCI is perceived by caregivers and family friend supporters. So the first step is to adapt the text messages from the diabetes treatment to autism early intervention. So we adapted the messages, then we brought this to our community advisory board and asked for their feedback. Our community advisory board is comprised of family members, early intervention providers, agency leaders, regional center leadership and members, and also family resource center members. They have previously provided feedback at different stages of the research project for Mind the Gap. And in addition to the feedback on text messages, we also asked for their input on the potential educational materials and topics for the supporters. So similar to the original fans text messages, our text messages include instrumental, educational, and emotional support messages. Here are some examples. Um, Ask for help for organizing paperwork for child's services. Ask your loved ones to do an activity together today. Child is more motivated when they play with a toy that they like, and ask your loved ones what toys their child loves to play. One piece of feedback received from our community members is to increase the use of plain language in messages. Some text messages are specifically related to early intervention strategies, and supporters may not necessarily have the context for that. So the board recommended including plain language, such as changing imitate to copy what the child does, and changing follow your child's lead to follow what your child does during play. And some of the emotional support text messages are related to self-care. For example, sending your loved one a cute animal picture, or tell your loved one it's time to throw something healthy in the lunchbox. And members of the um, community advisory board suggest that people have different methods of self-care. They recommended making those messages more culturally sensitive with more diverse options, and potentially asking caregivers about their own self-care methods early on. The community members also recommended including more positive messages to celebrate the family, celebrate and share small wins. So it could be something like text your family about something positive they have accomplished recently, praise them for their effort, and the message to the family could be share something small that you or your child has accomplished today. Um, And the community members also mentioned that it may be helpful to do goal setting with the supporters as well. What are their goals in joining the study, discussing the rationale of involving a supporter in this process. And they also provided feedback on frequency and timing of the text messages and information the supporter will be interested in obtaining. So we gave members a list of topics and resources for supporters and asked them to kind of pick the top three most important topics. Um, Understanding challenging behaviors, communication and language development, and overall developmental milestones were selected as the top three most frequently in this group. And so next phase, we move on to run a pilot study and test this out. We recruit providers who include caregiver coaching in their early intervention services, who has experience working with autistic children, and caregivers who have children between the age of 12 to 16 months, whether the child has autism diagnosis or a high likelihood of autism, and have a family or friend supporter who's willing to participate, to be part of the study with them. In this randomized controlled pilot trial, providers are randomized into either the fancy eye group or the treatment as usual. So we hope to answer we hope to answer three questions. Does fancy eye improve caregiver engagement? Does the fancy eye group report higher levels of social support and self-efficacy? How the program, how is the program perceived by participants? We're looking for. So this is what we're looking at the implementation outcomes. To what extent the FANS EI caregivers, supporters, and early intervention providers find the program to be feasible, acceptable, and appropriate, and will recommend to other families. Our first goal is to examine the effectiveness of NZI for improving caregiver engagement. So both the attitudinal and behavioral caregiver engagement will be measured. Attitudinal engagement will be measured through the caregiver buy-in to early intervention survey. So it asks the extent to which caregivers value the changes called for by the early intervention, believe that early intervention is good for their child, and um, believe that early intervention kind of creates positive changes in their child. Behavioral engagement will be assessed by measuring attrition rate, number of sessions attended, and cancellations, and also use the parent participation engagement measure. That examines to what extent caregivers engage in uh, participation behaviors during sessions, like asking provider questions, sharing their point of view of the child, participating in activities. So FancyEye overall is a text-based program that uses mobile health methods to build on the existing family and friend support network. FancyEye supporters, they participate in a joint introductory session with the caregiver and provider. Early intervention providers can introduce the program and set goals with the participants. Supporters have the option, but are not required to attend early intervention sessions with the family if they wish to, and the family agrees. And supporters will receive a digital link to the asynchronous educational materials at enrollment. FancyEye supporters and caregivers receive text messages from the research team in the evening around three times a week for the duration of the early intervention for 6 months. The messages to supporters mirror the caregivers' messages. Participants receive one message from each support category each week. So instrumental support, emotional or motivational support, and educational support. And the 3 messages per week are sent out in random orders. So what are the next steps? We're in the recruitment phase and data collection phase, recruiting early intervention providers and families they work with. We'll hopefully have more data to report back in a year or two. From a research point of view, the next step would be to learn more from this pilot study, make necessary changes and adaptations, and test it in a larger trial. And with a larger trial, we hope to explore the mechanism of change. From implementation point of view, if this is proved to be effective, could potentially help early intervention agencies kind of adopt a mobile health program based on their needs and potentially individualize the messages based on the specific early intervention provided within the agency. We will receive feedback from supporters and caregivers in this pilot, specifically what information will be helpful and meaningful for supporters in order to better help the family. I would be interested in taking a closer look at that support needs and to better tailor how we can engage that existing networks. And this might vary depending on different factors, right? The age, culture, race, ethnicity, other co-occurring conditions the child may have. A mobile health approach is a low-cost method that could be a key way to deliver support in a scalable and accessible way. That includes automated message delivery and minimal provider time required. So we'll continue exploring how to incorporate a mobile health approach to enhance social support and to improve engagement. Caregiver engagement in early intervention for autism is crucial for achieving optimal outcomes for both caregivers and their children. And the ultimate goal is to use a strength-based approach, low burden approach to support caregivers in those early intervention programs, increase service access, maximum the treatment outcomes for caregivers and their child. I'd like to close by acknowledging the individuals and groups who made this work possible. First, I want to thank the Mind the Gap Community Advisory Board, whose input was essential in shaping this project. I'm also deeply grateful to my mentors, Doctors Alban Stamer, Rachel Hinschlegel, Sandy Magana, Jim Morrison, for their guidance and support through this work. I'd like to acknowledge our team, including Walter Cervantes and the Collab Star Lab at the Mining Institute for their support. Finally, this research was supported by funding from the National Institute of Health, including the National Center for Advancing Translational Sciences and the National Institute of Mental Health. Thank you.